Welcome, everyone. My name is Tricia Rogers, and I am the Program Officer for the Northern Virginia Health Foundation. The Foundation is the only health philanthropy serving all of Northern Virginia. Its mission is to improve the health and healthcare of Northern Virginia's low-income, uninsured, and underinsured residents. Today, we are pleased to offer a webinar on how to maximize revenue from telehealth visits, a way of delivering patient care that more and more providers, such as yourself, are utilizing. Our expert presenters today are from RS&F, whose healthcare division provides consulting services to all kinds of practices in the Mid-Atlantic region. A question and answer period will follow their presentation, and you can submit your questions during their presentation using the chat feature. Please note, this webinar is being recorded. The webinar and the slide deck will be posted on our website, as will the questions and answers. And with that, I'm going to turn it over to the experts from RS&F, starting with Sarah Clark.
Thank you, Tricia. And good morning, everyone, or good afternoon, I should say. And thank you, Northern Virginia Health Foundation, for the opportunity to present on embracing telehealth. We are delighted to be with all of you virtually today. Next slide, please. For our agenda, again, I'm Sarah Clark, and I will be discussing the benefits of telehealth services during COVID-19 and beyond. I will also discuss some cybersecurity considerations. And Marie Polino will follow with information on coding and billing for telehealth reimbursement. And as Tricia mentioned, please submit any questions that you have during this presentation. And Marie and I, and also another senior consultant, Denise Walsh, will address your questions at the end of the presentation. Next slide, please. So why use telehealth? Telehealth has gone from a gradual but steady rise in adoption to now being an indispensable option during COVID-19. During the pandemic, telehealth services have demonstrated that it can increase patient engagement as it fulfills many of the face-to-face visit requirements for a medical visit. It removes the physical barriers in obtaining healthcare services, and it has the ability to use remote patient monitoring to manage chronic diseases such as diabetes and COPD. It deepens customer relationships by providing the care when and where they need it. Just imagine the working mom who doesn't have to spend 2.5 hours to have a 20-minute patient visit. It also allows family members to be more connected in healthcare decision-making. So telehealth is really expanding access to primary care and specialty services. And as an example, the Cleveland Clinic's Endocrinology and Metabolism Institute increased its virtual visits by 1,000%, or from 100 visits in February to 1,200 visits in March. So to avoid unnecessary hospital admissions and readmissions, a provider can connect to an individual in their home to assess his or her condition. And many ER visits are related to behavioral health conditions, and telehealth can really provide that connection to mental health specialists. And even prior to the pandemic, many ER departments and hospitals were using telehealth to connect directly to mental health specialists from their ER. So with the increased access to providers, telehealth services can reduce the use of the ER, which is a very costly component of healthcare spending in the US, and healthcare systems and payers are reviewing the data on this. Additional cost savings are transportation costs, in particular emergency transport costs, missed appointments costs, reducing penalties associated with unnecessary hospital admissions and readmissions, and really positioning facilities and organizations to qualify for value-based incentives. So with telehealth, you're really creating a new business model for healthcare delivery. And it's a model that will have a broader reach to patients and providers, healing patients in place and really promoting coordinated care, and improving the outcomes and health of your community residents. It does require that you reevaluate the services within your organization that are better positioned for telehealth services versus in-person visits, reevaluating the roles of your nurses and staff in your organizations, establishing partnerships with hospitals and specialists, and really expanding your primary care connections. And as important with all of this is really analyzing your technology platform, not only for connecting for telehealth visits, but also to provide remote patient monitoring and also connecting with your referral sources. So it's been highly broadcast. Telehealth has been instrumental in continuing to provide healthcare services during COVID-19 and reducing risk exposure. And we can certainly expect this to continue. MedStar was on the news and they reported that they went from 25 telehealth visits in a day to up to 4,000 system-wide during the pandemic. Next slide, please. So different use cases for patient to provider, that's when the customer finds and initiates the visit. So this would be a patient in their home connecting to a provider to, they think they have the flu or they want to get diagnosed for some particular condition. And then provider to provider or primary care connecting to a specialist to discuss treatments for a patient. And then provider to patient. This is the provider reaching out to the patient to inform them of their lab results or for medication management. So care coordination services. Next slide, please. So effective March 1st and throughout the public health emergency, Medicare is making payment for professional services furnished to beneficiaries in all areas of the country and in all settings. Previously, this was limited to more rural areas. And Medicare is considering telehealth services the same as in-person services and paid at the same rate. No costly technology is required. HHS is authorizing the use of telephones that have audio and video capabilities for furnishing these services. Next slide, please. So coinsurance and deductibles are still applied to telehealth services, but the OIG is allowing providers to reduce or waive the cost sharing for these services. And some payers are covering the out-of-pocket expense for a COVID-19 emergency, but it is important that you look at each individual payer because they're kind of addressing this in their own unique and different ways. So telehealth coverage will continue to evolve and change our healthcare system post-COVID-19. Next slide, please. So some of the basic minimums for telehealth services is, your video visit, and CMS has really relaxed its enforcements of HIPAA regulations during COVID-19. So you see providers using FaceTime and Zoom. We can expect, though, that CMS will start reinforcing their HIPAA guidelines and cybersecurity regulations post this pandemic. So you want to start evaluating if the tools that you're using now are something that you can use in the future. Also, you want better tools that not only can allow for the visit, but that you can also use for scheduling your appointments, that have mobile apps, secure messaging, and that are fully integrated with whatever EHR platform that you're using. Next slide, please. So we're in a telehealth revolution, and it's incumbent for healthcare leaders and administrators to collect and analyze the data to determine the best means of utilizing telehealth to benefit patients, providers, health systems, and communities. And it's an opportunity to really reduce healthcare disparities for patients with limited access to healthcare and to increase engagements in health education of patients. But with that, it's not sustainable if your providers aren't compensated for it. So Marie Polina is going to take over from here and talk about coding and billing for telehealth reimbursement. Thank you very much.
Thank you, Sarah, and thank you all for attending. I'm going to talk about the expanded access to care and their associated CPT codes. These slides will contain a lot of specific reporting information will be made available to all participants for future reference. I will move quickly through some of the repetitive detail in order to have sufficient time for questions at the end of the presentation. Please enter your questions through the chat box during the presentation. Next slide, please. CMS was the first payer to announce the major changes to the requirements of telehealth. Prior to COVID, telehealth had a unique place of service to report telehealth services and a limited number of CPT codes that were telehealth eligible. These codes impacted the payment amounts for the telehealth service. Medicare hurriedly changed their reporting rules to maintain the payment rates and to expand covered services. In order to reduce errors in claim processing and reduce errors in rejected claims, many commercial payers revised their existing telehealth reporting instructions as well, leading to additional confusion. There is no universal guidance, so one of the key takeaways is to check regularly with your contracted payers. There are links to the individual payer websites and tools at the end of the presentation to assist you. Telehealth services are identified to the payers by use of modifiers and by places of service code. So these are particular to the different payers. Next slide, please. So telehealth has been synonymous with virtual care. There's actually three types of virtual care. The first type, which we're going to be primarily focusing on, is the actual telehealth service, telemedicine evaluation and management services. This typically is through real-time telephone and video communication devices through a HIPAA compliant vendor. Though in the face of the emergency, some of these payers have have waived the restriction to this technology. The second type is the virtual check-in, which has been a telephone-only type of service. Medicare has always covered a virtual check-in, but have also added additional telephone-only codes. Then this is the use of a telephone only, not a smartphone. And then the third type is called an e-visit or referred to as an e-visit. These are the online digital evaluations. That is, they're not conducted in real time, but are asynchronous communication through a patient portal. And there are CPT codes to report these services. Next slide, please. Primary providers and specialists can now provide telehealth services to all of their patients during the state of emergency. They would continue to bill these CPT codes listed here that represent office visits. Any situation where the patient would typically go to a provider's office for an evaluation and management service is now payable as a telehealth visit no matter where the patient lives. Before, the patient had to be located in an HSA or health shortage area, but now the patients are located in their homes in any geographic location. This includes primary care and visits to specialists who report their office-based services with these E&M codes, and place of service 11 should be reported per payer instruction. These providers can obtain the full non-facility payment rate for telehealth. Prior to the emergency, Medicare paid the facility rate for telehealth services as a standard payment rate. Next slide, please. In general, most payers are still requiring that the long-standing guidelines for E&M service reporting must be followed for selecting a telehealth level of service. Code selection for the level of telehealth service is based on meeting or exceeding the level of history, physical exam, and medical decision-making documented within the visit note. This means that you have to meet or exceed the level in 3 out of the 3 components for new patients and only 2 out of the 3 components for established patients. Since the exam component might be quite limited, new patient visit levels may trend lower than your normal billing. However, established patient visits can be based on the level of history and medical decision-making documented, which may keep your visit levels consistent. And new patients can be seen by telehealth. There has been a common misconception that all telehealth could only be provided to established patients. The documentation should be the same as if the visit were performed in person, except to include the telehealth platform, and patient consent to telehealth care must also be included in the patient's medical record. Next slide, please. But relative to code selection though, Medicare made a leap forward. In the context of the state of emergency, CMS has issued other guidance for code selection of the primary E&M services that are the office visit codes. CMS is now allowing the level of service to be based on only the level of medical decision-making demonstrated or the amount of time spent on the encounter. This new criteria is aligned with upcoming changes effective for 2021 to promote patients over paperwork and is currently effective in 2020 for Medicare and Medicaid reporting. Commercial payers appear to be following the traditional telehealth documentation guidelines. The final 2021 criteria is not followed to the letter. The medical decision-making levels are based on the 2020 guidelines. Next slide, please. If using the medical decision-making, only 99201 code is eliminated from the code set, as it's the same level as a 99202. 99211, level 1 for an established patient, can be a nursing telehealth visit. So level 2 visits would generally be a visit for a single minor problem where reassurance and rest is offered. Level 3, low complexity, is typically a visit for a single acute problem with over-the-counter medication offered. Level 4, moderate complexity, would typically be a new problem to the examiner with prescription medication or multiple stable chronic medications being managed. Level 5, high complexity medical decision-making, would typically be a new problem or exacerbated established problems where there is a high risk of mortality or severe functional impairment caused by the associated problems. So make sure you're documenting whether the problems are new or established, the review of test results, medical records, discussion with other providers, document if history is obtained through other caregivers, and document the severity and the risks to treatment planning. Next slide, please. For Medicare purposes, time-based coding is no longer just the duration of face-to-face time spent with the patient. The amount of time typically associated with the level of service within the CPT description is now the reference point for the total time, including face-to-face and non-face-to-face time spent on the day of the encounter. This includes time spent in preparation for the telehealth visit and time documenting the telehealth visit. This option will make it code selection easier, but may undervalue the service if your patient is complex and requires more staff time. Time-based coding can only count the time of the billing provider. Make sure you document the total duration of the encounter in your encounter note. Next slide, please. This chart is repeated throughout the presentation to indicate the different reporting instructions for 7 major payers. For each payer, for the code set indicated, we've shown the telecommunication method required for telehealth, which place of service code is required for telehealth, which modifier is required or modifiers are allowed for telehealth, and if the service is primarily covered. For instance, Medicare does not allow a telehealth service to be billed the same as an in-person visit if only a telephone was used. Medicare requires interactive audio and visual, and Medicare requires the normal place of service for full payment or place of service too, but I would recommend the normal place of service. And Medicare, who prior to the emergency did not require a modifier for a telehealth service, now requires modifier 95. Normal place of service means that you should use the place of service code where the provider normally sees patient. But as you can see, Medicaid requires place of service 02. All three payers listed here request different modifiers to indicate telehealth. So you'll want to refer back to these charts for more detailed reporting information. Anthem requires place of service 02 as well. Next slide, please. Aetna requires place of service 02 and modifier 95. United, you'll notice that United Healthcare and Anthem on the previous slide, we have allowed audio only for as a method of communication for telehealth service. And this was to allow access to care for patients, primarily elderly or at-risk populations who didn't have access to a smartphone, to be allowed to have care by their providers using telehealth. So Anthem, United Healthcare, and Cigna allow audio only, but audio only would be the last resort. Every effort should be made to use a HIPAA compliant interactive telecommunication device or to provide the best quality of care. Next slide, please. Home visits were not historically covered as telehealth service, but have been added to the Medicare list of telehealth eligible services due to the emergency. These codes should not be confused with visits where the patient is in their home using telehealth only because of the COVID-19 stay-at-home orders. You may use these codes if you have any providers who would normally make a house call to a homebound patient. Reimbursement is greater for these true home visits versus office visits. So make sure that you're not confusing a telehealth office visit to a patient in their home instead of reporting the home visit. Next slide, please. Home visit codes should be used, home visit place of service should be used when the normal place of service is the home. For Medicare, you would report place of service code 12. Other payers would still require place of service 02 in these instances. So in each of these charts will still indicate for this code set the type of method of communication, the place of service code requested by the payer, and which modifiers the payers are requesting to indicate that the service is a telehealth service. Next slide, please. So again, there is a singular place of service for a home visit. So where the payer requests normal place of service, I have indicated place of service 12 as the place of service. Next slide, please. So preventative medicine is a large component of care provided in primary care specialties. This is where many providers have seen a downturn in business or downturn in their patient care. However, some preventative services can be covered when rendered as telehealth services. This code set is the preventative services covered by Medicare. Patients should continue to undergo their annual wellness services. It is important to assess patients' wellness risk during these uncertain times. Risk for alcohol misuse and depression is greater during a state of emergency, regardless of the type of emergency. Patients should be informed that they should schedule these services with whomever they would normally receive them from, typically their primary care providers. I have frequently been asked, how can a provider bill for an annual wellness visit if the patient doesn't have a scale or a BP cuff at home? So I've addressed it in this slide. If you cannot obtain the measurements, you can ask about signs or symptoms that may indicate abnormality. You can, if a patient has a history of obesity, you can ask them about their dietary changes. You can do a visual assessment of weight. And just for the lack of the exact measurement does not mean that you cannot bill for the preventive annual wellness visits during this time. Also, additional screening and risk assessment services are also covered and can be found on the link to the complete list of Medicare telehealth services at the end of the presentation. Next slide, please. This code set is for reporting comprehensive routine physicals, as they are commonly called. And these are reported to non-Medicare payers, as Medicare does not cover routine physicals. Due to the nature of the service, they typically are not a telehealth eligible service. However, due to the emergency and its timeline, this may change as conditions continue. Next slide, please. So Medicare does not cover the preventative medicine codes, only their specific kick-pick codes that were indicated on the previous slides and others on the comprehensive list of Medicare telehealth eligible services. So these services would have to be performed via interactive audio and visual. The normal place of service where they would be performed is reported, and modifier 95 is reported. Medicaid and Anthem Blue Cross Blue Shield do not cover these services as a telehealth service. Next slide, please. Aetna, United Healthcare, and Cigna also do not cover these services as telehealth service. However, Care First of Maryland, Blue Cross Blue Shield of Maryland, has included these in their list of telehealth payable codes. They include the routine physical codes. They instruct providers to report place of service owed to, but specifically say no modifier for these codes. So you can't just you have to really check with your payers in the specific instructions. Next slide, please. Transitional care management is primarily provided by primary care providers. Part of this service is inherently a telehealth service as it requires non-face-to-face communication and a face-to-face visit. The face-to-face component can be performed via telehealth. Transitional care is medical and social management of the patient during the time period following discharge from an acute care setting back into their community. This includes transitioning back to their homes or other non-acute care settings following discharge from an acute care setting such as a hospital or intensive rehabilitation program. This service is essential to prevent readmissions and are typically performed by the primary care provider who should be notified by the discharging facility. The face-to-face visit that is required can be performed if deemed appropriate. There is a note on this. Face-to-face visit must be an audio-visual visit, but that is the reference. Next slide, please. The payer allows audio only for a telehealth visit. The face-to-face component for the transitional care management can be performed by telephone only if deemed appropriate by the provider. And again, the place of service should be reported where the transitional care face-to-face component would normally have taken place. Next slide, please. And again, this is the individual reporting guidance is indicated here. The payers that allow audio only, the face-to-face component does not have to be interactive audio and visual if the patient does not have access to an interactive audio platform. Next slide, please. I've also included advanced care planning as it is primarily provided by primary care specialties. This service is not designated as a telehealth service in the CPT book. However, Medicare has always included it as an established telehealth service. Other payers vary by coverage. It is more frequently provided to the elderly and chronically ill who are often Medicare patients. 99497 is also a qualifying visit service for an FQHC visit. It is a good time to address patients' advanced care plan as previous delegated decision makers may no longer be capable or present to make decision for a patient during the state of emergency. These services are payable when performed by physicians and other qualified healthcare providers. This is an important service to provide to patients, particularly during this time of the COVID emergency. Next slide, please. And again, here is the individual payer guidance and coverage is indicated. Medicaid does not provide payment for advanced care planning services. Anthem, Blue Cross Blue Shield does. Next slide, please. And Anthem, Aetna, United Healthcare, and Cigna are listed as covered per patient policy, meaning that you should check the patient's benefit for coverage via telehealth. Care First has included this service as a temporary addition to telehealth eligible services during the emergency. So as the timeline of the virus continues, these rules are revised, it's important to continually check the payer websites for changes and revisions to the policies. Next slide, please. Moving on into behavioral health care, we're already hearing stories of increased domestic violence, the rush to divorce, relapses in addiction, and a mental health crisis is predicted as the COVID emergency measures and fear of illness continue. The full range of behavioral health services, including group therapy, are telehealth eligible now in any geographic area. These services are typically performed in a wide variety of locations. If the behavioral health is normally done in the office, the place of service 11 is reported. All other alternative settings should be reported with the corresponding place of service code when instructed to report normal place of service. Report the appropriate modifier as requested by the payer. The CMS has also included as a temporary addition psychological and neuropsychological testing services beyond the regular psychotherapy and diagnostic evaluations. And this is to support and what everyone perceives as an increased need for behavioral health services. Next slide, please. Another variation and for behavioral health care services, most payers, including Medicare, and have made revisions to, and audio-only communication is allowed to report behavioral health services as a telehealth service, including group therapy. Zoom may be a better option for group therapy. These flexibilities were created to expand access to treatment of behavioral and mental health issues during this stressful period. There's going to be a need for family counseling, anxiety, and depression treatments. It is important that these services are scheduled and captured for billing and not lost just as telephone advice given over to the phone, given free over the phone. Make sure you're capturing these services. Medicare, Medicaid, and Blue Cross Blue Shield allow audio only with their corresponding requested places of service and modifiers. Next slide, please. Aetna, United Healthcare, Cigna also offer these codes to be billed as telehealth services using telephone communication only. CareFirst, however, has not published any guidance relative to changing their requirement that an interactive audio and visual communication device be used to report a telehealth service. So every effort should be made to connect by a smartphone at the very least, especially for your CareFirst patients. Next slide, please. Moving on to teledentistry. Teledentistry is meant to provide oral health consultation and education over a virtual platform. You wouldn't think that dentistry could be performed without hands prodding and drilling. Nobody likes to go to the dentist. However, during the emergency, dental insurers and DMAS is allowing coverage of limited services via telehealth to promote oral hygiene and to triage. This allows compensation for providers remotely caring for their patients during the crisis. A dentist or hygienist can provide teledentistry services that they are allowed to provide in person. Next slide, please. This chart shows the coverage as published by Virginia Medicaid. Dental providers should check with any additional contracted payers for individual benefits. For Medicaid, you would report the service, a case management service or a limited oral evaluation or a real evaluation. That is the procedure that you would be performing through teledentistry. You would report that service along with the teledentistry code that indicates how the teledentistry service was administered. D9995 indicates that it was an interactive real-time encounter, and that has a payment rate of $35 in addition to the service fee. And if it was performed via asynchronous, not real-time teledentistry technology, the payment rate is $15 in addition to the service procedure. Medicaid is allowing 4 visits for teledentistry services per 6-month period per patient. For some payers, the teledentistry codes indicating if it was real-time or not real-time, these codes are used as modifier codes indicating the means of communication and do not affect the payment rate for the service code they are accepting to be performed via telehealth, such as a limited oral evaluation. Next slide, please. So now we're moving into the second type of virtual care and moving away from the telehealth services. Historically, most payers would never allow any payment for non-face-to-face services. CMS has added the telephone-only platform to their covered virtual care, and other payers followed suit. This was done to allow payment for care provided to patients who could not access smartphone technology. This was commonly the elderly and more at-risk populations. In addition to telephone E&M services, telephone E&M services were added for providers who normally cannot bill face-to-face evaluation and management services, such as the provider types as qualified non-physician healthcare professionals. These therapists can now be paid for telephonic medical discussion with their patients where other telehealth service code requirements are not met for billing purposes. Next slide, please. So if you have been billing for telephone calls to your Medicare patients in beginning March when they first allowed this, you should go back and check your reimbursements. At the end of April, Medicare has significantly increased the reimbursements for these procedure codes for physicians and other qualified healthcare professionals. They've just about tripled the rate. So this revision was announced in April 30th. Medicare announced that they would automatically reprocess claims. However, if your fees were set according to the old reimbursement rates or the original reimbursement rates, you may not get the full payment. So you'll want to go back and examine any prior billings to make sure that you obtain the full payment increased rate for these services, which are telephone services. The procedure codes for 98966 through 98968 are not as greatly reimbursed, but clinical psychologists and social workers should report these services when counseling is done by telephone only where the duration of time does not meet the psychotherapy service length. For instance, like if a therapist does a 10-minute evaluation or counsels a patient for around 10 minutes and cannot meet the basic level of a psychotherapy service, these codes can be reported. And the description of these codes include that the patient should be an established patient. That CMS has waived the restriction included in the nomenclature that limits these codes to only established patients, and most other payers have also followed suit. And if the telephone service results in an immediate appointment, these codes should not be reported. Next slide, please. So Medicare allows these codes. Medicaid does not allow these codes. They did not add them to the fee schedule. However, Medicaid does allow a telephone service to be billed as an E&M service. So you would report your E&M service when it's only with a telephone only. Anthem does cover these services by telephone only, and the normal place of service are always required for these services. They are not truly telehealth services, and no modifiers are required. Next slide, please. Other commercial payers have added these codes to their fee schedule prior to the arrival of COVID. I have providers in other areas that bill for telephone E&M services when managing a patient while they are on weekend call. Normally, patients might have taken an opportunity to phone for a prescription on a weekend and would not expect to be paid, expect to be charged. But now that if you get into the practice of informing patients that telephone services are covered and will be charged, you can capture these services even when it's not in the light of an emergency. These codes are to be used when the billing provider is performing the medical discussion. These are not to be used for nursing staff discussions. And I wanted to point out that CareFirst has limited these codes to only primary care specialties and only pays the same flat rate for all 3 levels of service. Next slide, please. The third type of virtual care was the online digital evaluation, otherwise known as e-visits. Do not confuse these codes with other actual telehealth or telephone services, telephone E&M services, as there is limited reimbursement. This type of virtual visit is conducted with the patient logging into your portal and messaging a complaint with a description of their problem. The provider can message back to inquire further about the problem to qualify the duration, severity of the problem, modifying factors, and a review of organ system. The patient responds back with additional detail. In the end, a disposition is determined, maybe to fill a prescription or to monitor symptoms using over-the-counter treatments, and if no better, than to schedule an appointment or to go for lab testing. This is not done in real time. So the time is accumulated during the episode over a 7-day period, and the reporting is based on time. Next slide, please. These codes were covered by Medicare historically and some payers prior to allowing the telephone-only codes. At this point in time, you should try to contact the patient by telephone to manage the problem to obtain a better reimbursement for your time. It would be unusual now that the patient can only access a provider through their computer and not by phone. So it would behoove you to really go away from the e-visit and use a telephone and bill a telephone E&M service where allowed, or the telephone only service where allowed. And these services can be provided to new patients, which differentiates from the definition that is in the nomenclature of the CPT code. And non-qualified physicians, which are the physicians, qualified non-physician healthcare professionals are therapists, physical therapists, occupational therapists, clinical psychologists who normally don't report E&M services can report these G codes and get compensated for their services. Next slide, please. And the individual payer information is listed here relative to these e-visits. Medicare does allow them normal place of service, no modifier. Medicaid does not cover them, and the MCOs do not cover them. Anthem, Blue Cross Blue Shield of Virginia does cover these codes with a normal place of service, no modifier. Next slide, please. Aetna, United Healthcare allow these services. At this time, Cigna and CareFirst have not published any change to their non-coverage of these types of services. Next slide, please. As a reminder, document telehealth the same as you would document an in-person encounter. Providers may telephone patients to inform that they can provide medical services by phone now, and these services can be covered by their insurance. There are requirements to document patient consent, which can be obtained by the provider and included in the note or obtained by staff prior to the telehealth appointment and maintained in the patient's medical record. Consent may be given verbally by the participant and documented by the provider or the staff. Consent need only be per year. Telephone only and virtual check-ins should be patient initiated and consented. Next slide, please. Now we're going to talk about some of the Medicare differentiations for an FQHC reporting to Medicare Part A. There is special coding guidance for reporting telehealth services performed by FQHC providers billing for their capitated visit rate. Any FQHC provider may furnish telehealth services that they are licensed to provide and are qualified to perform. The FQHC providers are not required to be located in the center when they are providing the telehealth service. FQHCs should follow all other telehealth reporting guidelines if billing as a fee-for-service provider to other payers as previously discussed in this presentation. Next slide, please. So when FQHCs are acting as the distance site, they would report 3 codes on their claim forms. The FQHC should report the new or established medical or mental health visit code for payment processing should be listed. They're the G codes, G4s, G0466 through G0470. And these are the HCPC codes that just say it's a federally qualified healthcare visit, new or established medical or mental health. Then you would then list the CPT or HCPC qualifying visit code that was performed via the telehealth, such as your E&M code or an annual wellness visit or a qualified behavioral health service. Then the G2025 is reported with modifier 95 to indicate that this qualifying service to the Federal Health Care Center was a telehealth visit, and this will process for payment accordingly. The current published rate is $92.03. Beginning July 1, 2020, report only the G2025 code with no modifier, with your HCPCS code describing the qualifying service. Next slide, please. FQHC are allowed to bill for the virtual check-in services. The telephone-only E&Ms do not appear to be payable to the FQHCs at this time, but they can report the virtual check-ins and the e-visits, which were always covered by Medicare. The FQHC should report code G0071 for payment, and then the qualifying virtual check-in visit code to be processed for Medicare allowed virtual visits. Next slide, please. Historically, a patient had to go to a provider's office or a facility to obtain a telehealth service. For that service, a provider's office or facility would bill an originating site fee. These fees have not gone away if provided. If you can, in fact, set up a telehealth visit for a patient in your setting to another provider or specialist on a given date, you can still bill for the originating site fee. The geographic location restriction is waived. So the specific CPT code to Medicare Part B and to report as this service is Q3014. FQHC should add the cost of telehealth platforms to their cost reports, though this code is not separately payable when added to their reporting services, as if they do function as an originating site fee. Next slide, please. So here we are in the virus. The virus is ongoing, and you may be seeing visits for screening and testing. So visits for screening or testing with a physician or a qualified healthcare provider should be reported at the level of service provided that day using one of the aforementioned visit codes. Individual cost sharing applies per the patient's healthcare plan. Medicare already waives costs for lab services for all tests, but will now waive cost sharing for any visit that results in an order for the COVID-19 test or the collection of the test. When reporting an E&M service, along with any testing procedures, append modifier CS to the E&M code reported to Medicare to collect full payment for the E&M service that day and waive the cost sharing for the patient or the cost sharing that may be billed to the secondary insurance of a Medicare patient. Next slide, please. If you are a testing site and or if no other evaluation and management service is performed that day, 99211 may be reported as a minimal evaluation and management service to only requesting the test. This 99211 can be reported for specimen collection. CMS has removed the restriction that it has to be an established patient when it is performed as an incidental service performed by clinical staff or nursing staff. And append modifier CS to 99211 to waive any cost sharing for this service if you are reporting this as a specimen collection service. Next slide, please. With the arrival of the novella virus, we got a new diagnosis code. When you have a confirmed case of COVID-19, you may report ICD-10 code U07.1. Until confirmation is obtained, you can report any of the status codes indicated here to report with the specimen collection service to process for payment. You would only report the Z codes if there are no other signs or symptoms. So if a patient is worried because of contact or exposure of where they're working or family members, these status codes can be reported with a specimen collection test, or if they need additional counseling, if you go beyond specimen collection, these fears are causing general need for provider time and may be reported with an E&M service. Next slide, please. But always report signs and symptoms first if any of these are present, in addition to the exposures or other non-COVID conditions that you may be reporting. Report these conditions to any other, like if you have a patient that's coming in for an evaluation or it's a telehealth visit for their follow-up of diabetes, and they have any of these symptoms and you want to order the test, add these signs and symptoms or any other exposure diagnoses onto your claim form when reporting the service. Next slide, please. As mentioned earlier, it is important to check each payer for specific guidance for telehealth billing, especially during this time of rapidly changing rules. This tool, which is provided by the American Academy of Professional Coders, is a free tool to locate all health plans by state with links to their billing manuals online. You can find other payers that we could not address specifically in this webinar. So we have a link to the page here. When you get to the page, you search on your state, and all the states, all the plans that are licensed to operate in your state can be found. And then you'll find the link to that payer's website. And I urge you to constantly look for changes to this and check other payers that you may be contracted with. Next slide, please. So we've had additional tools that you'll be able to reference after the webinar. And on these next two slides, we can move through these and then we'll open it up for questions and answers.
Thanks, Marie. You did a great job. I have a couple questions here, and I just want to remind everybody that if you have any questions, please type them into the chat box now. We have a few minutes left, so we'll try to get through those questions. So, Marie, I have one question that asks, can mental health services be billed for preparation and documentation times?
The psychotherapy services should not count those time requirements that are going to be effective for 2021 are only applicable to the E&M codes that are for office visits and outpatient department visits, the 99201 through 99215 code set. Other codes should follow their typical requirements for documentation for the CPT definition. So for a mental health visit should be the duration of the counseling time.
Okay, thank you. We have another question. Can a telephone visit be coded based on medical decision-making only, or does it have to be based on the time spent?
If you're talking about the telephone E&M code, the 99441 through 99443, the telephone E&M service, those are time-based. So that is not based on the medical decision-making, but the amount of time incurred for the medical discussion. But again, if you have a complex medical decision-making being done and the patient is insured by a payer that allows an audio-only call, you should go back to the E&M codes to elevate that service where applicable. But just to also follow up, Medicare, they increased their levels of time to match the reimbursement for a level 2 office visit, a level 3 office visit, and a level 4 office visit. So if you have a 20-minute discussion or 21-minute discussion with a patient, you're going to get the same from Medicare as you would a 99214.
Okay, thank you. If you are using time-based coding, can you include the time a provider helps a patient set up the technology necessary to perform the telehealth visit? Example, helping an elderly patient set up a Zoom meeting.
If the billing provider is doing that, that time should be included as the total time spent on the encounter, and you could code accordingly.
Thank you. We have a statement here from one of our pediatric practices that says that Medicaid and the Medicaid MCOs are covering well child visits. They have been billing and they have been getting paid for those well child visits. So I just wanted to let everybody know that.
Thank you for letting us know that.
They change constantly, and not all of the guidelines are listed on their websites.
And we will update our information and support tools to reflect that. Thank you.
There's a question regarding access to all of this information after the webinar, and yes, the slide deck as well as the questions will be posted on the website. If you have any other questions, we still have a couple more minutes if you want to post them in the chat box. I think that's it for our questions.
Well, thank you, Marie and Denise and Sarah, for this information-packed webinar. Again, I will repeat that the recording of the webinar and the slide deck will be posted on our website, which is novahealthfdn.org. And if after this presentation you have some questions, you can email them to Marie or Sarah. And can we have the slide with their email addresses on it? There you go. And with that, that concludes our presentation today. And thank you for participating.